Pulkit ji.
Hello. Yeah. So very warm welcome to all the doctors and all the panelists for today's discussion on heart in diabetes, special interest group diabetes India. So I welcome you on this discussion. Next.
Okay, thank you
So
so much,
today,
Pulkit ji.
yeah,
Thank you so much for your warm introduction.
yeah,
As you know that with the ongoing series of diabetes dynamics, this is the sixth episode, the sixth iteration of our webinar. In the current webinar series, we are focusing on special interest groups of Diabetes India, which is for the build-up of Diabetes India World Congress, which is happening on 13th of February to 16th of February in Ahmedabad. So I welcome all of you to join us in Diabetes India, which is happening in Ahmedabad. So for today's session, our moderator is Dr. Mikhil Kothari. Mikhil Kothari is a physician and diabetologist based in Mumbai. So over to you, Mikhil, sir.
Good evening, everyone. Thank you so much for joining in for our Christmas Eve episode of Diabetes Dynamics, special interest group, Diabetes India. Today's topic will be heart in diabetes. Without further ado, let me introduce the Dr. Akash Singh. Sir is the Director, Senior Consultant of Spandan Multi-Speciality Hospital, Vadodara. So handing over the guys to you, sir.
Good evening, everybody who has joined in to listen to this webinar. Today I'll be talking about heart in diabetes. And unfortunately, my co-speaker, Dr. Sajeev Phatak, has not been able to join. So I will have to deliver on his part also, although I do not have his PPT, but I will deliver something from my own side. Now, diabetes is a major risk factor for CVD. Additional risk factors for CVD are common in diabetes. And as you can see that major cause of morbidity and mortality in diabetes are coronary heart disease and the cardiac complications. Now, if you see type 2 diabetes is increasingly prevalent and CVD is the leading cause of death in this population. The diabetic patients have a 1.76 times greater relative risk of severe mortality, and CVD is the principal cause of death in type 2 diabetes. If you see the cardiological complications in diabetic patients, you have patients across the spectrum of diabetes which come to you. This is the entire spectrum of diabetic patients which come to you. And a lot of these patients have associated CVD or CVD risk factors, and a lot of these also have associated CKD, which enhances the risk of CVD. So the diabetes, cardiological, renal, and metabolic, all of these basically go hand in hand in creating excess of heart disease in patients of diabetes. Now, if you see the patients of diabetes with comorbidities across from 2022 to the projections till 2045, you will see that type 2 diabetes with obesity and overweight is on the rise. Type 2 diabetes with hypertension is on the rise. Type 2 diabetes with dyslipidemia is on the rise. If you go through the INDAB ICMR 2023 data, basically, you can see that in India, 101.3 million patients with diabetes, 136 million patients with pre-diabetes are present. And along with them are patients which are basically huge numbers with dysglycemia, hypertension, generalized obesity, abdominal obesity, and dyslipidemia. So all of these are basically present in huge numbers and they all lead to heart disease. If you see the co-prevalence of comorbid conditions and complications in South Indian phenotype, you can see that type 2 diabetes with dyslipidemia, type 2 diabetes hypertension, type 2 diabetes with CKD, you can see the numbers, basically percentages on the screen. Type 2 diabetes with obesity, type 2 diabetes with CVD, type 2 diabetes with dyslipidemia with hypertension, type 2 diabetes with dyslipidemia with obesity, type 2 diabetes with CKD, dyslipidemia, type 2 diabetes with hypertension, CKD. So you can see the numbers are huge, and all of these conditions go hand in hand in the genesis of heart disease in patients of diabetes. Now, this is also very, very important data from Indian diabetes study. We studied the newly diagnosed Indian type 2 diabetes patients, and you can see that CAD is increasing both separately amongst patients younger than 40 years of age, which is worrisome. 10 to 25% of the MIs in India occur before 40 years. More than 50% of CAD associated deaths in India occur before 50 years of age. So, young diabetics getting into heart disease with excess morbidity and mortality. And if you risk stratify these patients, then almost two-thirds are classified as very high risk. 82.5% appear to have at least one cholesterol abnormality, and 96.5% presented with lipid values above recommended range. So, a very, very high incidence of diabetes related comorbidities and metabolic abnormalities which lead to heart disease. Now, this was the Cindy 2 studies which studied population in the younger age less than 40. And if you see less than 20 years, almost 25% have obesity and 75% have increase in LDL-C basically. If you go to the population range between 21 to 40, then very, very huge numbers showing smoking, hypertension, overweight, obesity, and LDL-C. All of these basically translate into excess risk of heart disease in population below 40 in our Indian population. If we see the correlation of heart disease in type 1 diabetes, you can see this study basically which shows that five-fold higher mortality in type 1 diabetes compared to the general population. This is the Allegheny County data basically. If you see the all cause and severity mortality in type 1 diabetes, then control Swedish registry, you can see that the severity mortality is higher in the diabetic population, which you can see here basically. Now, what are the reasons for higher heart disease in patients with diabetes? The suboptimal glucose control is still higher in type 1 diabetics than in type 2 diabetics or in controls. If you see the weight gain trajectories with the emphasis of intensive glucose control, the weight is rising. As you can see in the intensive group, the weight gain is more. In this cardiac trial, again, the weight gain is more in the intensive group. You can see the trends in BMI more than 25. The numbers are increasing from almost 30, one-third of the patient in 1986-87, now rising to two-thirds basically. So the weight is increasing basically, although it has been increased with increased adoption of intensive insulin therapy. Updated mean BMI was associated with increased risk of CVD after multivariate illnesses. So the increase in BMI is offsetting the better control of diabetes and causing excess of heart disease. The cumulative CVD incidence by weight gain, as the weight gain occurs more and more, the incidence of CVD also goes up. Another thing which is seen in type 1 diabetes is they are also displaying features of type 2. That is, the insulin resistance is getting more common in type 1 diabetes, which leads to excess risk of heart disease in your patients. Now, if you see, this is the 1996 and this is the 1999. The blood pressure has is better basically in 1919 compared to 1996. Still, the heart disease is more, and this is basically because we do not have clinical data to guide blood pressure treatments in type 1 diabetes. We are following the type 2 diabetes, and data on the optimal antihypertensive treatment to minimize severity risk in this population is also absent. If you see the lipid severity risk and type 1 diabetes, you can see that lipid concentrations are generally within the recommended levels in patients with type 1 diabetes, yet they predict severity risk. So it is possible that lower levels are required to be maintained in patients of type 1 diabetes, and the guidelines we have are basically for type 2 diabetes. Also, there are no lack of trials basically in age group of less than 40 years, where very less trials basically, and therefore we do not have adequate data. Coming to pre-diabetes and the risk of heart disease, the risk of heart disease goes up by 13% basically in patients of pre-diabetes, and this is seen as the fasting sugars go above 100. So as you move from a spectrum of HbA1c 5.7 towards 6.4, the incidence of heart disease increases in this population. If you see compare the CVD risk in non-diabetics, which is on this side compared to diabetics, you can see that the risk of heart failure, stable angina, non-fatal MI, and coronary artery disease is more in diabetics compared to pre-diabetics. So what it means? It means that there are 2 to 4-fold higher risk of CVD in diabetic populations, twofold higher risk of heart failure in diabetic populations, 50% excess risk of severe death in patients of diabetes, and the lifespan in adults more than 50 years old is cut down to the tune of 7.5 years in men and 8.2 years in women because of diabetes. And major complication is because of heart disease. Now, the common soil hypothesis states that there is an onset of subendocardial dysfunction in patients of diabetes in all the major peripheral arterial circulations, basically, which translates into CVD, CKD, eye disease, liver and foot disease, and all of these conditions combined with diabetes will exacerbate the onset of heart disease. Now, the risk of heart disease not only starts at the diagnosis of pre-diabetes, it starts much earlier, basically. It starts right from the stage where the insulin resistance sets in, because once the insulin resistance sets in, you have typical diabetic dyslipidemia, which comes into picture, high triglycerides, low HDL, glycosylated LDL, small dense LDL, dysfunction HDL, all of these lipid abnormalities set in, and there is an excess risk of heart disease, which sets in right at the stage of insulin resistance. And by the time you diagnose prediabetes and diabetes, already many of these patients have subclinical or clinical heart disease, which is present. Now, endothelial dysfunctions leads to remodeling, hypertrophy, which leads to MI and heart failure, plaque formation, which leads to peripheral artery disease, TIA, stroke, and aortic aneurysms, and kidney disease, the early kidney disease, that is microbulimia, renal insufficiency, which leads to overproteinemia and renal disease, which translates into excess risk of heart disease. So, if I summarize the risk factors which contribute to excess risk of heart disease in patients with type 2 diabetes, there is a state of hyperinsulinemia, which leads to, as you know, weight gain, and the dyslipidemia, which sets in, hypertension, which leads to the excess stiffening of the arteries, and the arterial resistance is basically affected. The genetic predisposition, and that leads to hyperglycemia, the advanced glycemic end products set in, which leads to increased risk of prothrombotic factors are there, basically. In the skeletal muscles, there is insulin resistance, which leads to increased free fatty acids in the circulation and state of hyperglycemia, because the skeletal muscles consume a lot of glucose, and there's a beta oxidation molecules basically required for skeletal muscle energy, and all of these two factors affected leading to hyperglycemia and increased levels of free fatty acids. Lipemia is there, basically. There is excess of adipocytes, especially in the visceral bed, which leads to the pro-inflammatory and the pro-thrombotic factors setting in, or leading to the accelerated atherosclerosis and risk of heart disease. Insulin resistance also leads to something called as metabolic dysregulation or metabolic inflexibility, because the Krebs cycle, the TC cycle is affected, less energy is generated, basically. The beta oxidation of fatty acids also occurs to a lesser extent. There is downsizing or downregulation of the GLUT receptors. All of this basically is to increase glucose in the circulation, increase free fatty acids in the circulation, basically. And what you do is that the metabolic rate goes down, basically. The energy expenditure goes down, and there is an excess deposition of fats in the fatty acids, all leading to excess risk of heart disease. If you see the pathophysiology of diabetes and heart failure, hyperglycemia, insulin resistance, hyperinsulinemia, all leads to the pro-inflammatory factors, endothelial dysfunction. There may be a macrovascular disease with a MI, basically leading to a systolic heart failure, or the cardiomyocytes basically there may excess death of cardiomyocytes, that is cardiomyocyte apoptosis. There is an excess generation of fibrous tissue around the myocardium. There is also hypertrophy of the myocardium. There are metabolic dysregulation in the form of disordered calcium handling, disordered fatty acid utilization, formation of advanced glycosyl end products. All of this basically lead to the myocardial functional impairment leading to diabetic cardiomyopathy, which may be diastolic in nature, basically. So you have systolic heart failure, diastolic heart failure, and both of these basically are leading to heart disease. If you see the hypertension with hyperglycemia, excess stimulation of the RAS system, immune activation, oxidative stress, inflammation, mRNA activation, all of this leads to macrovascular disease, and this leads to heart disease. If we see the coexisting conditions with diabetes, obesity basically is on the rise. Abdominal obesity is associated with increased risk of both diabetes and heart disease. Because of obesity, you have the bad chemokines, the bad hormones, which are in excess. There is a decrease in good hormones like adiponectin. The leptin resistance also develops. There are excess of inflammatory cytokines, which is more common in type 2 diabetes. So type 2 diabetes and insulin resistance leads to increased risk of all factors which leads to increased atherosclerosis. Coming to the coronary artery disease, if you see that diabetes doubles the risk of coronary artery disease, coronary death, and non-fatal MI. The dysglycemia is an independent risk factor for adverse CV outcomes. As you can see that the coronary heart disease is on the rise as the mean fasting glucose increases, and the vascular is also increased with the increase in the mean fasting glucose. So this is a famous study where they have studied patients which did not have diabetes but had a episode of MI, and those patients which had diabetes but no MI, and they followed up these patients for 7 years, and they say that almost equivalent risk of the second episode of MI in these both of these population. And this study basically gave the famous dictum that diabetes is a coronary artery disease equivalent, which is again a very controversial thing and a debatable thing. If both diabetes and MI are coexistent, then there is even excess is almost 45% of patients develop a second episode of MI after 7 years. Coming to dyslipidemia, you can see almost 85 to 98% patients of diabetes in India have dyslipidemia, which translates into excess risk of diabetes. This is a major study, MR-FIT study, where they studied the non-diabetic population and the diabetic population. And for equal concentration of lipids, the diabetic population had an increased risk of heart disease. So if you can see the Indian diabetic patients, they are ethnically different. They have high triglycerides, low HDL, more of small, dense LDL. Statins and TG lowering required to lower non-HDL-C for comprehensive management. So this is the difference. The small, dense LDL basically percolates in the intra-endothelial space and leads to formation of thrombotic plaques, which is more common. If you have large particles of LDL, then they are not that harmful. But small, dense, oxidized LDL particles are much more helpful because they can go into the endothelial space and generate the atheromas very fast. So if you see the hypercholesteremia, the awareness is very less, the treatment is even less, and the control is even less. So very few patients which have a dyslipidemia are controlled basically because of all of these factors. If you see the hypertension, each 20 by 10 millimeter BP increase doubles the risk of severe mortality. So hypertension control is also very important to control the heart disease, basically the onset and the complications of heart disease. Heart failure. Now, patients of type 2 diabetes have increased risk of CVD and heart failure, which often coexist. Often, half of all patients with type 2 diabetes have CVD. Hospitalization of heart failure is twofold higher in patients with diabetes. One in five without heart disease will develop it in next 5 years in diabetic population. So the heart failure is the commonest cardiovascular complication of type 2 diabetes. heart dysfunction may occur in diabetic regardless of other risk factors. And if you see these red lines are diabetes with heart failure with reduced infection, heart failure with preservation, and if you can see the cumulative incidence, the morbidity and mortality is much higher in both the subsets of heart failure population in diabetics compared to these blue lines which are in non-diabetics. So, poor glycemic control and longer duration of diabetes are associated with development of heart failure in diabetic population. So, if you see diabetes, they have excess of diabetic cardiomyopathy, mitochondrial dysfunction, abnormal calcium signaling, excess of oxidative stress, excess of RAS activation, atherosclerosis more, CAD is more, worsening renal failure is more, and all of these translates to heart failure. And in heart failure, there is more chances of these patients having diabetes, more chances of worsening of diabetes, more chances of sympathetic activation which worsens diabetes, RAS activation, and worsening renal function. So both of these basically conditions exacerbate each other. If you see the multiple trials done in patients of diabetes with heart failure, it is seen that if you go for intensive glucose control in patients with heart failure, it does not translate into better outcomes. So you have to play safe. You have to maintain your HbA1c to a level where you do not cause hypoglycemia. Hypoglycemia is to be strictly avoided, and you should not go for very stringent control in these subset of population because a single episode of hypoglycemia can precipitate heart failure. Coming to the drugs and heart failure, the buraglitazar, the rosiglitazone, all of these led to excess risk of heart failure, and this set in the US FDA guidelines that all new agents should be tested for CVD risk before they are certified and brought into the market for use, basically. And if you see the sexagliptin, alogliptin, sitagliptin, all of this, as far as the MACE is concerned, proved to be non-inferior to the standard drugs, basically. But if you see the heart failure hospitalization, sexagliptin in the severe TB trial showed a 27% increase in hospitalization for heart failure. And if you see alogliptin, there also the hospitalization for heart failure is more on a numerical basis, although it is not certified. So sexagliptin and alogliptin basically, this was a very some period where the DPP-4 as a class was thought to be causing more of hospital and heart failure, but the TECOS trial basically showed that sitagliptin is neutral as far as causation of hospitalization or heart failure is concerned, basically, and therefore, not all DPP-4 inhibitors are causing heart failure. If you see major adverse events and heart failure hospitalization, you can see that the sexagliptin and alogliptin are the only two drugs which cause excess risk of hospital and heart failure. The rest of all the drugs, including GLP-1 receptor agonists, are safe. Coming to CKD and diabetes, CKD in diabetes is very, very common. Basically, almost 40% patients of type 2 diabetes go on to develop CKD, and it has been seen that right from the stage of microalbuminuria, the risk of heart disease goes on increasing. And as the degree of CKD increases, the staging of CKD increases, the risk of heart disease increases basically. And because CKD is very common in diabetes, therefore, the risk of heart failure, heart disease is also on the rise in diabetic population. So these are basically the initial introductory part, which I was supposed to speak. Now I'll be talking on that part, which Dr. Sanjeev Phatak was supposed to speak. I will try to do justice to that part also. Coming to the management of CV risk in diabetics. Now, if you see come across a patient of diabetes, then you have to look for hypertension, presence of retinopathy, as it doubles the risk of CVD. You have to see for dyslipidemia, you have to see for presence of hyperuricemia, you have to see for duration diabetes, you have to screen for heart failure, you have to see the body mass index, smoking status, presence of albuminuria, microalbuminuria, you have to see the family history of premature coronary artery disease, sleep duration, all of these things you have to see. You have to risk stratify your patient basically. The normal scores, the ASCVD score, this and score, that score, will not tell you the exact risk. Basically, you have to go for specials because diabetes is basically a incremental risk factor or risk enhancer in patients and causes excess of heart disease. If you see the therapeutic options, lifestyle modifications in the form of weight optimization, healthy diet, increased activity level, adequate sleep, cessation of tobacco, cessation of smoking, cessation or moderation of alcohol, stress management with yoga and meditation, all play a major role in the control of heart disease. If you see the ADA recommendations for the management of heart disease and diabetes, it boils down to glycemic management, blood pressure management, lipid management, and the optimum use of agents with cardiovascular and kidney benefit. All of this basically are the four pillars of management of heart disease in patients of diabetes. Coming to the management of diabetes, you all are aware of this decision making chart. You have to individualize the patient, discuss the management plan with him, start in agreement with the patient, the management of diabetes, monitor the diabetes management, and review and modify the plan. The goals of diabetic management should be optimized, should be decided looking at the diabetes duration, life expectancy, important comorbidities, established vascular complications, patient preferences, and resources and support system. Accordingly, you don't have to stick to a very stringent HbA1c in patients where it is not justified. Early aggressive treatment is required because you, with the early treatment, you offset many of the long-term macro and macroscopic complications. And if you lose time early, basically, in the diabetes is when it's uncontrolled, you lose a lot of benefit, basically. So early management is very much required. Coming to the impact of intensive therapy in prevention of heart disease, you can see that the conventional treatment basically also does good. Basically, the intensive treatment, as far as the CVD is concerned, should be instituted early. There is no doubt. But if you're late and you go on very intensive treatment, it takes long, very, very long years basically before you derive CVD benefit. And here, prevention of heart disease is majorly benefited by lifestyle factors, by drugs like statins, by the newer drugs like SGLT2 inhibitors, GLP-1 receptor agonist, and these drugs basically have to be judiciously used. Coming to the control of blood pressure, there are new guidelines by ADA. These are old guidelines. The ADA guidelines say that if you have blood pressure beyond 150/90, straight away go for two agents rather than going for a single agent and stepping up on that. If the blood pressure is beyond 130/80 and up to 150/90, then you can use a single agent. And the drugs preferred in diabetics are ACE inhibitors or ARBs. Then you can add calcium channel blockers, diuretics, beta blockers, and then if the blood pressure is still not under control, then the other drugs can be used. Cardiovascular risk factor categories in type 2 diabetes, very high risk, severe risk, where you have type 2 diabetes with clinically established ASCVD or severe target organ damage or 10-year CVD risk more than 20% using scores 2 in diabetes. High severe risk is patient of 10-year CVD risk between 10 to 20% and moderate between 5 to 10% and low risk CVD risk is less than 5%. In those areas where the CV risk is borderline, you can go for additional tests like coronary calcium score basically. And if the coronary calcium score is beyond 100, it is 100 to 300 is moderate risk. Beyond 300 is high risk. So beyond 100, you can discuss with the patient, and if the patient is willing, you can start off with managements with the preventive strategies like lipid management in the form of statins and all. Now, coming to the primary prevention in diabetics, it is better to keep LDL less than 100. If patient already had established atherosclerotic cardiovascular disease, the numbers can come to less than 70%, less than 55%, and in very complex patients, less than 40% also. The primary prevention is with the help of statins, basically. If statins are not able to bring down the lipids to recommended levels, then ezetimibe can be added, or vampiric acid can be added, or PCSK9 inhibitors can be added, basically. If patient has intolerance to statin, which is seen in many cases, you can change the type of statin or reduce the dose of statin Additionally, you can add bemperoic acid, acetamide acid, PCSK9 inhibitors, and inclisiran is a new drug on the block which can be used. Coming to treatment of other lipoprotein fractions in diabetics, for individuals with fasting triglycerides more than 500, evaluate for secondary causes of hypertriglyceridemia and consider medical therapy to reduce the risk of pancreatitis. Between 175 to 499, you concentrate on lifestyle medication and rule out the secondary diseases which cause the triglyceride like obesity, metabolic syndrome, CKD. All of these, if you can control well, basically, you can bring it down by control of these secondary causes. Otherwise, you can go on medications. The drugs which are preferred is the uh, purified EPA, basically, in the dose of 4 to 8 grams daily, basically, which is the preferred drug. You can see that the purified EPA is the only drug which has been shown to improve the CVD morbidity and mortality and to decrease the LDL and triglyceride levels appreciably, basically. Statin with fibrate combination is also can be used basically, especially in India, because the purified EPA is very, very costly. In the field, we have field trial basically, which has shown 11% reduction in the risk of future CVD events. Statin plus niacin is no longer recommended basically. There is also a role of combination therapy because if the LDL levels are very high and you feel that the LDL levels will not be optimally controlled, even with the highest dose of statins, even at the initial phase, you can go for higher dose of statins combined with ezetimibe, combined with bempedoic or combined with PCSK9 inhibitors from the word go, from the initial part, to address the LDL and to decrease the risk of future heart disease in patients with diabetes. Antiplatelet is now majorly recommended for secondary prevention, basically aspirin for those not tolerating aspirin, clopidogrel, dual antiplatelet therapy, especially after PCI, after stroke. Long-term dual antiplatelet therapy should be considered for individuals with prior coronary interventions, high ischemic risk, and low bleeding risk. In patients with heart disease and peripheral artery disease, you can go ahead with aspirin with rivaroxaban or other NOACs basically. Aspirin therapy may be considered as a primary prevention strategy in those diabetic patients who are at high risk of future cardiovascular disease after a comprehensive discussion with the patient for the benefit versus risk of bleeding, because there is a 29% excess risk of bleeding over years in patients with diabetes. So if you get a patient who is more than 18 years old with type 2 diabetes and has more than one of the following ACE risk factors like ASCVD, heart failure, diabetic kidney disease, or is a high risk of ASCVD, you should address all of these concurrently, basically, and optimized guideline-directed medical therapy for prevention of all of these risk factors, including diabetes, should be managed well, basically. And here, the role of agents like GLP-1 receptor, which is the preferred agent for atherosclerotic cardiovascular disease, and SGLT2 inhibitors, which is the preferred agent for heart failure and CKD, should be added from the word go to the ongoing regimen to address the future risk of heart disease in these patients. And these are old slides actually. So these are ADA 2023, where they say that a patient has a atherosclerosis risk of atherosclerotic cardiovascular disease, then go ahead with as a GLP-1 receptor agonist, and you can add SGLT2 inhibitors to it basically to optimize the glycemic control and optimize the risk control, especially if patient is on the obese side. Or you can use SGLT2 if patient is not according GLP-1 receptor agonist. So from the word O, basically you have to use these agents. And even before metformin, you should be using SGLT2 inhibitors or GLP receptor agonist in your patients, basically in monotherapy or in combination therapy to address the excess risk of cardiac disease in patients of diabetes, basically. So SGLT2 inhibitors and GLP-1 receptors have good data, basically, and GLP-1 receptor agonists basically have the best data as far as the prevention of future atherosclerotic cardiovascular disease is concerned, and dulaglutide and semaglutide are the approved agents. If you see the multi-dimensional effect of SGLT2 inhibitors, it causes glycosuria, decreasing the calories. Basically, there is a negative caloric balance, which is favorable. HbA1c is decreased, uric acid excretion is increased, blood pressure decreased, plasma volume is decreased. There is a better tubuloglobal feedback, and there is excretion of sodium also. All of this basically leads to better improvement in the cardiac risk in your patients. Also, it improves the cardiac energetics in the failing heart. There is a stimulation of the erythropoiesis, which leads to better hematocrit, which also addresses the cardiac risk in a better fashion. There are actions with the NHE3 ribosomes, basically, which are the inflammatory ribosomes which cause excessive heart failure. Those also are addressed. So there are new mechanisms which are being discovered with the use of SGLT2, which benefit the heart basically. And all of these trials, basically the Empire, Canvas, Declare TB, Vertis, and now there are a lot of host of other trials which have come up, which have shown that these agents benefit heart basically, and none of them is detrimental to heart. The GLP-1 receptor agonists also work throughout the body to sort of improve the risk, atherosclerotic cardiovascular risk factor in your patients basically, and this also leads to a better control of the risk factors which lead to heart disease. And the best drugs in the GLP-1 receptor class to use are the dulaglutide and the semaglutide. And we have a lot of other drugs which are coming up, like tirzepatide, there's a GLP-1 and GIP agonist, and other drugs which basically will be available in future for these conditions. Even on the kidney front, the SGLT2 are the best drugs, but the GLP-1 receptor agonists also have some beneficial effect, and therefore they should be used in these agents. And this chart basically summarizes the effect of drug classes on CV risk, heart failure, and kidney outcomes. And you can see SGLT2 is the most versatile, followed by GLP receptor agonist, ACE inhibitors, ARB, statins, all of these basically should be used basically. ACE inhibitors and ARB should not be used concurrently because there is excess risk of nephrotoxicity and hyperkalemia in patients. So to summarize, the therapeutic considerations for patients with diabetes in cardiology clinic, it is not about, only about diabetic risk. You have to see the blood pressure lowering therapy. You have to see the lipid modifying therapy. You have to see the anti-thrombotic therapy. You have to see the diabetic therapies, especially the therapies like SGLT2 and GLP-1 receptor agonists which benefit the heart. You have to see the CKD management. You have to see the heart failure therapies, and all combined will lead to the best management for heart disease in patients of diabetes. So type 2 diabetes is increasingly prevalent, and the numbers of people with diabetes are projected to increase substantially, especially in Southeast Asia. Diabetes is a major risk factor for CVD. There is a clustering of additional risk factors for CVD in persons with diabetes. The risk of CVD increases right from the stage of prediabetes. Diabetes is a major risk of CAD, peripheral artery disease, heart failure, the most common CVD complications of diabetes. So thank you very much for the patient listening. And I'll request the moderators to take over the session. Thank you very much.
Thank you so much, sir. Now, moving on to the next session, that will be the panel discussion, for which I would like to invite Dr. Vitrag Shah. He's a consultant at Achintya Wellness Surat. Also, Dr. Kshitij Kumar, who's a consulting physician and diabetologist, St. Stephen's Hospital, New Delhi, and also Dr. Sagar Biradar. He's a diabetologist at SB Diabetes Center, Gulbarga. So now going ahead with the panel discussion, any questions from the listeners? So as such, from the panel itself, Have you seen any major change in trends in treatment in terms of heart health and diabetes care in your practice?
Hi, this is Dr. Shitish from Delhi. Currently practicing for last 10 years over here. Well, definitely, although sir has covered all aspect of how we're gonna treat, and he shared everything about how we can manage about each sequence. So, if we'll talk about our clinical practice, definitely the scenario has been changed. Nowadays, we see a very young patients which encounter in our hospital or in a clinic. Basically, the age group which we encounter is from 35 to 45 years, and basically it's a young age. And what we found over here while treating those patients who comes with uncontrolled diabetes, having associated hypertension, that is the biggest things which I encountered. So it is closely correlate with our lifestyle, definitely, and the diabetes. So the whole scenario has been changed because now almost 40-50% of those population who has uncontrolled diabetes have the hypertension. So the management, we need to be very clear about, we need to achieve our target as soon as possible. So now we have all the options which sir has described about the management.
Right. And have you have any of you noticed any such pattern in your practice where patients are coming up to you and specifically asking for certain kind of SGLT2 inhibitors or GLP-1 receptor agonists for
Yes,
the
yes, definitely.
benefits?
Yeah, definitely. Through the social media now, a lot of patients, they come up not with the GLP-1 RA, they come with that they found there is a new pill in the market about the weight loss, and somehow it is related with the diabetes also. They found it that, so they come with that and they said, oh, GLP-1, sir, there are some kind of medicine which we can treat with the diabetes and with the obesity as well as. So definitely GLP-1 RA, they somehow uh, managed to know about through the social media, but about the statin like other drugs, not yet.
Right. Is there anything else, Sir Doctor, would like to add?
There's a lot to it. Basically, that what beats the eye. So what happens is that everything is being blamed on genetics, basically, as far as genesis of diabetes and heart disease in India is concerned. But genes have not changed, and they cannot change so fast in the last 50 years. So what we are seeing is more of epigenetic factors which are causing an excess of risk of diabetes and heart disease. And all of these epigenetic factors are basically growing. That is the worrisome part because they are not on the wane, basically. Smoking is going, alcohol intake is going, the social media time is going, so the sleep is suffering, basically. The stress is growing because everybody is hassled up for the job, for all the materialistic things that they want to have in their life. The society has become more argumental, basically. So for small things, people get excited and they engage in discussions. The belief in what doctors say is decreasing, basically, and less patients are sort of adherent to therapy. If you offer them statins, if you offer them SGLT2 inhibitors, a lot of them question us. A lot of them basically would not agree to it. Basically, the use of alternative therapies is also rampant, basically. So all of these factors are basically creating that atmosphere that the heart disease incidence is not going down in our population, and there needs to be better efforts at primordial prevention rather than at primary and secondary prevention, because if you see the media, social media at large, and the government at large, there are no policies, basically, which there should be a very, very aggressive campaign against the sweeteners, against trans fats, against calorie dense foods, all of these for exercise, all of these things which should be advocated at the level of the society is not being done. And that is why the younger generation, the parents, the common people are not being guided properly. That is one thing. Second thing is that a lot of our people, in spite of adequate treatment, adequate medications, adequate lifestyle modifications, still suffering from early disease or from for a repeat episode of CAD or a cardiac episode. And here we should go into the other factors which can lead to these, and these are lipoprotein A levels. We can also go for other things which are now getting available, like the polygenic rate scoring of these patients, and all of these basically can give us additional information about additional factors. Like now, there are therapies which are being developed for the decreasing the lipoprotein A levels also. The PCSK, the newer versions are getting available. So all of these things also have to be basically taken into account if we are to decrease the risk of heart disease in patients with diabetes in our population. But the most important is the primordial prevention, which is nowhere in sight, and it is basically as part of a heart and diabetes group of Diabetes India. I think more aggressive advocacy of these primordial prevention strategies should be there on a mass level, basically.
To the panel, we have a question from Dr. R.V. Deshpande from Karnataka. This question is how do we balance the benefits and risks of statin therapy in diabetic patients? Any new lipid lowering agents that are particularly beneficial for patients with diabetes?
If anybody wants to answer, definitely they can go ahead. Otherwise, I'll answer. One thing which I would like to ask to Dr. Deshmukh is which sort of side effects he's talking about. Because as far as I know, statins hardly have any side effects. And they are one of the best tolerated medications. We have been using it for more than 2 decades. And there are hardly any patients who come in and tell them that they're not tolerating statins. So if patients are in very, very few cases, if they are not able to tolerate maximum dose statins or they are not on optimal LDL goal on those statins, we have innumerable drugs now. We have ezetimibe, basically, which can be added on. We have vampiric acid. All of these are basically very, very patient-friendly drugs with minimum side effects. We have PCSK9 inhibitors if they can afford, and inclisiran, which we can inject every 6 months, which is the best of part of it. You can just inject every 6 months, and you have 60 to 70% reduction of LDL, which is sustained for these 6 months. And all of these agents, basically, so we have a host of agents. We can always switch therapies. If suppose a patient is on rosuvastatin, we can try atorvastatin or pravastatin. So there are a lot of statins also available. So basically, as far as the statins are concerned, there are hardly any side effects. Majority of them basically are very, very easily consuming without any issues, basically. And if there are side effects, we have multiple options in store, basically. We can use either of these statins.
Thank you,
Sir,
sir.
in my just to sir, I wanted to ask one question as well. So in a very practical way, a lot of prescription which I saw in OPD, many primary doctors or like doctors, suppose it's a very vague question, but once they have the diabetes and hypertension, prophylactic they add the statin. How we can justify this? Like if you see several prescription, yeah, you will find although the cholesterol level is normal, LDL is okay, but you can find the statin, which is a test. So can you elaborate with that, sir? Like, is it a good way, or should we start with
No,
the statin?
no, no. We have very, very clear-cut guidelines, basically. as far as the initiation of statin is concerned in patients with diabetes. And all of these guidelines basically are majorly, you can say, tuned to age group of 40 to 75. Because between these age group, all of these studies have been done, major of those. Now, there are some studies which below 40, like Heart Protect study, but these studies are small basically. So, our major information is between 40 to 75 years of age, where major studies have been done. And what they say is that the target is to, if patient has diabetes and if he also has hypertension, then he
Mm.
becomes even at a high risk. We should target a LDL goal of at least 70. And if the LDL is already less than 70, then I think the guidelines would not recommend administration of statins. It is not a blanket treatment for all the patients. It is targeted to a specific LDL goal, and if that LDL goal is already met, then no need to add statin in these patients. All of these borderline patients, basically, we target if patient is only diabetic, then our target LDL may be different. But if patient has diabetes with smoking, diabetes with obesity, diabetes with hypertension, then diabetes, heart disease, and all of these, we have to individualize the target, and the target should be definitely lower than a patient has only diabetes with no other risk factor. So basically, a patient profile is very important to decide the level of LDL where we want to keep the levels basically. Regarding the HDL, basically, there has been no benefit which has been observed by increasing LDL. There have been several drugs which have been given, they have brought up HDL, sorry, by 40, 50, 60%. But no cardiovascular benefit has been found by increasing the HDL levels by these agents, basically, whether it may be niacin, whether it may be citraps. And therefore, HDL basically at best is a marker, is a risk factor of future cardiovascular disease. And the same is true for triglycerides also. Elevated triglycerides are again a marker of excess cardiovascular risk. But whether you will incur any benefit by decreasing only the triglycerides as in the form of future CVD risk is a question which is still which needs a lot of research, and the answer is still uncertain basically because US the ADA basically says that decreasing triglyceride is to prevent the risk of future pancreatitis. But again, a elevated triglyceride is a marker of excess CVD risk.
Thank you,
So,
sir.
To add on with this,
to
okay.
the panel, I would like to bring to notice Dr. Banshi sir has joined the discussion. So, would you like to speak on the topic as well? We're discussing diabetes and the heart. Banshi sir,
Good evening, sir.
Hello.
Hello,
good
sir.
evening, sir.
Just give me half a minute. I am just joining and opening
Good
my
evening.
in the chamber only in clinic. Just within a half a minute, I'm joining. How many doctors joined for this today's program?
127.
That's great. So first of all, congratulations, Rutul, for making this program. I just want to convey one thing: that Diabetes India we started different interest group. The idea is that diabetes itself is a disease with a lot of subspeciality, and many of us are not interested for everything. Someone will be interested in pediatric diabetes, somebody may be interested in diabetes complication, somebody may be in cardiac failure. So the point is that many of us may not be working for every field, and we thought of that we should have a different interest group. This is an idea of interest group internationally also. Different international organizations also do the same thing. In India, the response of different interest group was fantastic. We were having in different interest group more than 200 member almost in each and every group. Mostly we asked that one doctor can join two group only, and this was very very successful. And now more than 1500 doctors who joined in different interest group. A D Genius, which we started in 2018, the idea of that young diabetologist should become a part of this D Genius group. And Rutul is doing really fantastic job of creating this D Genius group with more than 400, 500 doctors from all over India. D Genius is a young diabetologist, and they thought of that we should do a one webinar with a different interest group. So this is one of its kind. A D Genius is joining with diabetes interest group, which is diabetes in hearts. But I'm surprised that today we have 150 doctor. I was thinking that we will have 1100. We have just done a meeting of diabetes and foot interest group, and there were 1100 doctors who were joining that. So why am I surprised? Because I was thinking that diabetes and heart is, more physicians are interested to discuss diabetes and heart rather than diabetes and foot. But we were having 1100 doctors in diabetes and foot program. The other good news is that this year we are going to have Diabetes India meeting with more than 3,000 delegates who will be there. You'll be surprised that before 31st December, the last date of submission of abstracts and last date of getting your fellowship, we have 200 plus fellows and more than 200 abstracts has already come. We are selecting that who should be given oral and who should be given short oral or who should be on a paper presentation. We have 1,500 doctors who are already registered for this meeting. We have 60 international faculty. We have almost 150 national faculty and more than 150 people who are in different interest group and this D Genius group who are already there as a part of our faculty. Plus 100 plus chairperson from different parts of the country as well as from Gujarat and Ahmedabad. So it will be a grand meeting. We will be having 2,500 to 3,500, roughly the number of estimated delegates which we are looking for, and it will be a meeting for 3 to 4 days. This meeting also have one unique thing that this year we are doing this meeting along with Diabetes Asia Study Group, which is a more than 50 countries of Asia. They are part of this Diabetes Asia, and we are getting almost doctors, delegates, as well as faculty from all these Asian countries. So we will be having around 25 Asian faculty and plus more than 200 delegates who are coming from different parts of the Asia. The Bangladesh, Sri Lanka, Nepal, Myanmar, Philippines, Indonesia, Malaysia. These are the countries from where we will be getting the delegates. So, I mean, it will be really a truly World Congress of Diabetes. So, we are very proud to say that this year in Ahmedabad, in Gujarat, we are going to have a World Congress of Diabetes. I am, as a being a National Secretary of Diabetes India, I congratulate Dr. Sanjeev Phatak, Organizing Secretary, and congratulating Dr. Manoj Chawla, who is organizing chairman, along with Shashank Joshi, who is program chair, and completely program is coordinated by Dr. Amit Gupta. I'm equally proud of Dr. Rutul, who is coordinating for Gujarat, for Ahmedabad, for D Genius, and all interest group, and he's really working very hard to make it grand successful. Those who are joining from Gujarat and Ahmedabad for this interest group meeting, I request them, as Rutul has planned one meeting along with Dr. Sanjeev Phatak on this Sunday, that is coming Sunday on 20, no, not coming Sunday, next to next, on 5th of January, in evening time, afternoon time, with tea at our venue. And that venue to just to show, and we will also trying to show the program details and how what we are doing in 4 days. With these words, thank you very much for all the delegates, all the participants, all the faculty member, all the interest group members, and all D Genius member who could join. And those who could not join, I'm sure that they will be joining for our next interest group meeting along with D Genius, requesting all D Genius members to work hard to make it more popular. So when there is a next meeting of D Genius, you should make sure that they all join for the meeting. At the same time, I am thanking USV for giving us an opportunity and giving us the platform. And in this platform also, they should show our second brochure. They should show our link of all registration and link of abstract submission if they can do, because we are planning to extend for next 15 days and we are expecting few more fellows because many of them are calling and we are not able to accept there because they don't have, I mean, who is their proposer or seconder. So, I mean, that's the reason we may do it for next 10 to 15 days. With this, I am thanking once again to everyone and good night. Thank you.
Good, sir. Thank you,
Thank
sir.
you so much, sir.
Thank you
Thank you.
so much, sir.
Bye bye.
Thank you, sir. Bye.
Thank you, sir. Chandigarh wanted to ask on what are the key points one should focus on when educating patients about the benefits and risks of gliptins.
Well, gliptin is one of its kind. It's one of the very wonderful drug which we have it in a current scenario, gliptin. Although we can say to the patients that first is a kidney friendly. There is a no dose modification with the gliptin mostly. Second, in a cardiovascular disease or any heart patients, we can give gliptins. Third, with the liver problems, we can give it without any problem. Fourth, it's a weight neutral. Fifth, there is a no hypoglycemic problems which we encounter with the gliptins. So these 5 points easily you can say how the safe molecule it is while initiating to all those diabetic patients. Only risk factor is UTI, definitely. This we can uh, tell. But if the patient faces any kind of problem, we can deal with that. We should not stop the medicine. We should treat first.
So, may I interrupt, Dr. Kshitij, as it was the question was about gliptin and
Leptins.
not SGLT2 inhibitors.
Sorry.
Yeah.
Yeah. So
So
if there is
I'll
another,
tell you
yeah,
about
some,
itself,
yeah.
gliptins. So first is that is the beautiful action is that is the glucose dependent action. So once we put the patients on gliptins and we have a very less fear of hypoglycemia. If patient doesn't show up, it has delayed follow up. Usually very well tolerated in all the patients. It has on an average very modest HbA1c reduction, 0.5 to 1% we can say for almost every gliptin. Hypoglycemia, weight neutrality. The other beautiful thing is that is orally administered, no injections. So patients' adherence to the therapy is also very good, and most of the gliptins have very good cardiovascular safety. If we consider about the risk factors while educating the patient, there are very minor side effects which are very much negligible in many of our patients. That is just like nasopharyngitis, mild headache, upper respiratory tract infection, and in extreme cases, sometimes pancreatitis may. But I don't think I have seen any patients on gliptins who have developed pancreatitis. But one thing that we should take a proper history of past history of pancreatitis in patients before putting the patients on gliptins. Some gliptins like saxagliptin have some heart failure risk, but that we are not have been using much in our routine clinical practice. Apart from few gliptins, there are only one or two gliptins required renal dose modifications. One more, I can say a drawback that in very high levels of blood sugar levels or very high HbA1c levels, sometimes gliptins are not that much effective. So once we are taking
Yeah,
good
sometimes they work like placebo.
the gliptins, then it is
True.
a very well option for considering to reduce the risk of hypoglycemia. And most economical thing that we should consider in our patients that are benefits over the economy. So most of the gliptins are now very much cost effective. So our patient adherence to the therapy improves very well.
So to add on with
So
this,
one thing I want to add, if you allow. Yeah.
Yes, sir.
For hospitalization due to heart failure, if you see, really all the gliptins have a black box warning. Only, I would say that linagliptin is one of the safest among all. Otherwise, for hospitalization due to heart failure, we should consider this black box warning as saxagliptin and alogliptin uh, has been showing increasing hospitalization due to heart failure, except CETA and other teneligliptin. Teneligliptin, we don't have data much, and linagliptin only is considered to be safe in hospitalization due to heart failure. So we should keep it in mind. whenever the patient who has borderline heart failure and ejection fraction between 30 to 45, and many of the patient where reduced ejection fraction is not there, then we should be very much cautious about prescribing DPP4 inhibitors.
Exactly, sir. So I was talking about the linagliptin only, not all gliptins. So my all points were only for linagliptin only.
To
Okay.
add up to this, I'd like to be very happy that, like, to add on with hypoglycemia, when the patient comes to you with an hypoglycemia and he has a fear of hypoglycemia, so adding on the gliptins, removing sulfonylureas will help us to the most of the time in the clinical practice. That can be resolved easily, as everybody and other benefits, as all of you has discussed. So hypoglycemia can be tackled with the gliptins again.
Just one more question to add. Hmm. Has anyone encountered pancreatitis due to gliptin? Or it is just a warning that has been given as a blanket? Because I haven't seen yet pancreatitis which is due to gliptin.
Not yet, sir. For last 8 years, I haven't
No,
seen
no,
any.
no.
Got it.
So I
So,
recently had just today I had a patient who didn't have pancreatitis, but he was on liraglutide and he had elevated lipase. So lipase was 262. However, amylase was in the normal range of 42. So how to tackle such cases who are on GLP-1 RS and who have partially elevated either of the pancreatic enzymes? So should we put them on any of the pancreatic enzymes, or we should just stop the GLP-1 therapy?
You should ideally stop it for a few months and you should repeat it and recheck it whether lipase is coming down, and and you can restart it again and check it again. So there is only one way. I don't think that giving pancreatic enzyme is good idea for this thing. As on the other hand, we are giving GLP-1, we are continuing it, can worsen the situation.
Ninat, can you add on with a few other information, like what all the findings you could find with the patient? Why is
The
it that?
patient actually he doesn't had steatoria. He doesn't have any of nausea or vomiting, any symptoms. He didn't have pain. It was just a random test which was done because the patient was on GLP-1. Totally
I've,
asymptomatic.
I've seen a case of semaglutide-induced pancreatitis. That did happen. But specifically gliptins, not so much. GLP-1 RAs, yes, quite a bit. Quite a few cases of acute pancreatitis or suspected acute pancreatitis.
And among DPP4 inhibitors, vildagliptin has been showing increasing liver enzymes. This is what
Yeah.
is common, and I have seen this. So
Sir,
and yes.
sir, vildagliptin with which dose? 100 maximum dose or with the moderate one?
So in most of the cases, we use the maximum dose because the efficacy of any gliptin is very low. So there is no point of giving half dose except linagliptin or sitagliptin, where we need to reduce the dose. In linagliptin, they did not have metformin sustained release, so this is why they came up with 2.5 by 500 or
Yeah.
2.5 by 1000. Otherwise, we don't need to reduce the dose of gliptin except reduce renal function. So, with full dose only, we have seen this.
Okay.
But with DPP4, this is not related to the heart. But the most interesting side effect is this manifestation on the skin. So a lot of
It is
those
very much
cases,
common. Yeah, skin
plus with
manifestations are
Vilda.
too common with DPP4
Yeah.
Pemphigus is very common. Even I have 4 to 6
inhibitors, though
cases
Yes.
we
on
consider it as
DPP4
like
inhibitor.
any skin disease, and patient directly goes to dermatologist and they don't even ask us.
Right.
Yes.
Yeah.
So uh, I think we can end the session if Nikhil
So,
sir.
yes. So I believe Dr. Pulkit has to have a word, and he'll take over next.
Yeah. So thank you all today's speaker, all the delegates and all panelists. USV and this D Genius group. USV always support young and enthusiastic doctor who are interested in providing care in the diabetes management. For this, we bring you Diabetes Dynamic series for young diabetologists to improve their knowledge and practice. So this is in this series, this D Genius webinar is there. So going through this USV, which is your reliable healthcare partner. Next slide, which is 62 years young in healthcare. One out of every fifth prescription in diabetes contains USV oral anti-diabetic brand. USV is a leader in cardiology by prescription. USV is leader in diabetes in orals by value and prescriptions. We are global leaders in metformin, and one out of every six tablets sold in the world of metformin is supplied by USV. And USV is a presence in 66 countries. Next. Our profound gratitude to each and every one of you, your family, uh, being an integral part of our journey. Our aim to partner is to ensure better patient care so that India can be recognized as a metabolic care capital rather than a metabolic capital of the world. So, next. Uh, and our roots are deeply ingrained in our Indian history. Our founder, Dr. Vitthal Balakrishna Gandhi, here in left side, and his successor Arvind Vitthal Gandhi, and current leadership is Mrs. Leena Gandhi Tiwari and Mr. Prashant Tiwari is there. Our there are the backbone of our business is world class manufacturing campus, active pharmaceutical ingredient plant. We are having an API plant of Chiplun and API Ambernath plant is there. And we are also having finished dosage formulation plants that is in Nerul, which is biological manufacturing facility, and Daman we are having finished dosage formulation, and Baddi we are also having finished dosage formulation plant. And we are having world-class manufacturing facility, dedicated plant of glycomate GP at Vadodara itself, and dedicated plant of EcoSpring AV Baddi at Himachal Pradesh. We are being a sustainable, responsible manufacturing unit, untouched by hand, solar power usage 600 megawatts, zero liquid discharge, rainwater harvesting is there in these two plants. Paperless manufacturing laboratories are there. Green belts are there, that is 800 trees and 3,111 square meter area is there in this. And one of the sixth world requirement of metformin is supplied by USV, and quality of USV metformin as FDA as per specification NDMA should be placed greater than or equal to 0.032 ppm or 96 nanogram per day. Analysis result of most recent 44 batches of glycomet sustained list confirm that glycomet SR NDMA level in glycomet SR 1000 milligram, glycomet SR 850 milligram, and glycomet SR 500 milligram was less than 0.01 ppm or 30 nanogram per day. We are having leader brands in cardiology and diabetology, that is in EcoSprin AV, EcoSprin Gold, Ticaspan, Ricosprin, Glynas MF, Triglynas, Glycomet GP, Glycomet Trio, Glycomet GP Star, Insuquick, Liralin, Jalra range is there, Udapa range is there, and Rose Day, Benzi, and Teslock range is there. Next. We believe that knowing is not enough, we must apply. Wishing is not enough, we must do. And if you want to see the change, be the change. So we are aware of the challenges in diabetes, that is disease awareness, screening and diagnosis, education and research, infrastructure and capacity building. Life without a purpose is meaningless. So we have a purpose which is beyond the business, to be a part of your and your patient's journey. We are having disease awareness screening that is more than 10 decades by that is TV, radio, FB Live, Insta, and print medium is there. We want to do something for today so that our future generation will thank us. Although we can't change the world, but we can definitely do our bit. Our partnership with HCP is more than 6 decades, and we are having screening more than 5 decades in hypertension, complication, diabetes, obesity, screening and diagnosis is happening. Encouraging research, that is 2000, that is we are having ESI AV Gandhi Award for Excellence in Endocrinology, AV Gandhi SCAI Award for Excellence in Cardiology, and AV Gandhi Award for Excellence in PhD Endocrinology and Evidence Genesis. India Diabetes Prevention Program was supported by USV also. And Our continuous medical education collaboration with SCAI, the Association of Physicians of India, Indian Society of Hypertension and Endocrine Society of India is also there. Also, our partnership, next slide. Our partnership is more than with SCP is more than 6 decades. We are having beta course, that is ECG learning for paramedics, also Save a Life, an initiative to educate the people on symptoms of heart attack, and training of more than 1 lakh people including paramedics on how to resuscitate in emergency situation like sudden cardiac arrest, and NDEP program that is entering into 14th year, which is created 22,000 diabetes educator in India. Also, next slide. We are having India Insulin Education Program, that is My Care program, a type 1 diabetes education program, NIEP program, CIEP, and Insulinization for India program is there. Next slide. That is, we believe in sustainability, so we want to do something for today so that our future generation will thank us for, although we can't change the world, but we can definitely do our bit. We are using solar energy usage, and because of that, sir, we reduced by 4,000 carbon dioxide emission by reduced by 4,000 tons per year. And also we are having green insulin, that is recycled plastic waste created by our insulin pens and NG spun TR bottle to make our product plastic neutral, and also to create awareness on right disposal of sharp and insulin needles. Next. So thank you. So I would like to thank on behalf of USV today's speaker, Dr. Akash Singh sir. Also, today's moderator, Dr. Mikhil Kothari sir, and Dr. Vitraksha, Dr. Kshitij Kumar, Dr. Sagar Biradar sir, and also thank you, Dr. Rutul sir and Dr. Ninaz sir, and also very encouraging talk, Dr. Bansi Sabu sir. Yeah. So thank you also USV Tech team. Yeah. So we can end the session. Thank you very much for your warm presence over here.